Hello, I'm John Gribben and welcome to iwNHL, where we're here in sunny San Diego, where we've had a very fruitful day one. I'm joined by my fellow scientific committee members, Wyndham Wilson, Laurence de Leval, Catherine Bollard, to discuss the sessions we've had today. So we started off today with a session on T-cell lymphoma, which you chaired. It's true to say that there's been huge advances in our understanding of the molecular pathogenesis of T-cell lymphomas. What did you take away from the session this morning?
I approve, of course, what you said. Has been an explosion of discoveries in the genetics, the molecular biology of those diseases. The timing is in a way right, because that's the time the WHO classification is also revised, and some of these novel discoveries have now been included in the new classification. So that was summarized by Dr. Jaffe this morning, and among the several changes that have been introduced, I think an important one is the consideration now that among the nodal lymphomas, those that are derived from follicular helper T cells, the paradigm being angioimmunoblastic T-cell lymphoma, but there are also companion lesions that belong to the same group will now be put under the same umbrella. And that makes a lot of sense, because not only for the pathologist, those lymphomas look close to each other, but very interestingly, it appears that they also they share some common molecular alterations. So I think it's a very good example where a group of tumors is sharing characteristics at different levels, and probably it's a very stable group of disease. One cannot say that the same is true for all the current entities, because the knowledge is still very imperfect, and what is striking is the major heterogeneity in those diseases. So everybody is conscious that some of the entities may still be provisional, or others might be grouped together, but that's how it is for the moment.
Sure. Now, one would hope that these advances in our understanding of pathophysiology would, as they have done in diseases like CLL, lead to paradigm shifts in terms of treatment, but that hasn't quite happened in the T-cell lymphomas yet. Is that something we can expect will happen, or is there just something, is that heterogeneity you discussed just make it much more difficult to believe that there's going to be an easy win here in terms of new therapeutic breakthroughs in this disease?
Well, that was emphasized by Dr. Foss this morning. The difficulty, first of all, to get patients on trial, and I think, as I understood, it's highly contributed by the global rarity of those diseases together with their heterogeneity, but it was also expressed an urgent need to change the way to handle those patients and to come up with some more effective combination therapies. One of the questions also was how to identify the patients that would be the best candidates for stem cell transplantation. Some results are expected from ongoing studies as to regarding which entities respond best to certain categories of new therapies. I'm thinking of demethylating or agents or HDAC inhibitors that appear to be more effective on some of the entities, and that will allow to design novel trials.
There are a lot of ongoing trials which Francine Foss discussed, which should read out in the relatively near future, giving us some clues as to whether that approach is likely to be beneficial.
Exactly.
Sure.
So I think that we can draw parallels with what we've been learning in some of the B-cell lymphomas. Yes, there is tremendous heterogeneity within the T-cell groups, but there's also heterogeneity within B-cell lymphomas as well. but a overarching abnormality has been B cell receptor signaling.
And now we see an
And now
overarching
we
T-cell
see
receptor signaling.
there is overarching T cell receptor signaling. And we now know that drugs that are inhibiting B cell receptor signaling work across multiple different B cell lymphoma types. And I think that we can easily start to look at drugs that perhaps can inhibit TCR receptor signaling. And so simply categorizing tumors by whether or not there's evidence of T cell receptor signaling, and also whether or not there may be downstream of activating mutations that may make upstream targeting not work, needs to be worked out as well. But I think until we start to molecularly characterize these tumors and use specific targeted agents, we're going to be throwing drugs at a very heterogeneous group of tumors. And because they are so heterogeneous and rare, we're going to have a very difficult time finding a signal. So I think we need to move away from simply taking drugs and throwing them across many tumors, and to be much smarter about it.
Sure. So thinking of being smarter about it, we moved on to a whole session on the treatment of the young individuals, where the challenge we have almost is that the responses are so high that looking for differences can be quite subtle. And you chaired a debate, Kath, on the whole notion of, should an 18-year-old be treated with pediatric or adult protocols. A lot of it kind of raises the issue as to why there are such differences in the way that pediatricians approach, and we can come back in a moment whether we do call it the same disease or not, but this whole question of why historically has this whole divide occurred?
I mean, I think, the way we did the debate today really was from a pediatric and an adult perspective, but we were really focused, as you say, on this AYA population. And certainly the pediatric oncologists come at it with an ALL background. Most of what they treat is ALL, and so their therapy is very focused in a sort of an ALL type.
It's the first time I've heard a pediatrician admit that the whole idea of giving high-dose methotrexate with intrathecal methotrexate at the same time, something I've never been able to. And now that, of course, we're having to adopt many of these pediatric protocols, I have to say I scratch my head every time I see it and say, why am I doing an intrathecal in someone I've just given 5 grams per meter squared of methotrexate to when it crosses the blood-brain barrier so effectively?
Exactly, and I think that's what was so important about today, to really bring together people that treat pediatric patients and people that treat predominantly adult patients, and really realize where this sort of grey zone is, which is unfortunately the AYA population, where they're overlapping between either walking into a pediatrician's office or a medical oncologist's office. I think that as you heard today, there's still a lot of controversy about how these patients should be treated. And I think
even from the
pediatricians. And I think it really sort of signaled the fact that pediatric oncologists and medical oncologists have to come together to design sensible trials for that particular population, because for sure we don't know enough about the biology of that population in particular, so we need to think about how we can discover more about what is their specific biology and what is the right treatment for them. Should they get a pediatric regimen if they have diffuse large B-cell lymphoma, where they're going to be forced to have a more ALL type regimen, versus if they walked into a medical oncologist's office and they would get an adult lymphoma regimen such as dose-adjusted EPOCH-R or R-CHOP. So we need to really move forward in that field research-wise.
As a pediatrician, is it just like ALL? Do you think they're over-treating some cases?
So we absolutely think there's a proportion of our patients we're over-treating, without a doubt. But when you're dealing with overall survival rates of 95+%, event-free survival rates of 94, 95, how do you withdraw it when failure is not an option because the salvage rates is less than 15%? So this is what we grapple with when you are faced with a young adolescent or young adult.
So I actually want to comment on that, because I think that this is a philosophical question that I think has really not served young patients well. Because the cure rates are so high, and because they've not differentiated, for example, Burkitt's from large cell, they have been unwilling to accept, I think, very good data from adults that could speak to the fact that large cell lymphomas do not need high-dose methotrexate. They refuse to do that. Similarly, we've known in every setting in which Rituximab has been applied in adults for CD20 positive curable diseases, it has improved outcome. It also allows you to almost certainly use less aggressive therapy. And yet it has taken literally a decade and more in order for the pediatricians to even do those clinical trials. And then finally, I think this also applies to Hodgkin's. We have now known for adults, we have been pulling back radiotherapy that has long-term adverse effects. But the pediatric groups have been unwilling to look at the adult experience, and they have lagged behind, pulling back a very dangerous therapy, RT, for many, many years, over this idea that, well, we're curing them all, so we don't want to make any rapid changes. So I personally think...
Didn't I just hear that radiotherapy was hardly used at all in the pediatric sector?
So I think in the defense of the pediatric oncologist, we have dialed back...
Hodgkin's.
Oh, Hodgkin's.
Yeah, Hodgkin's, I think, with the Hodgkin community is finally realizing that radiation is not...
But in young adults, that's the population we want to use at least.
Right, yeah.
But it's taken over, it's been running about a decade behind.
But I think on a positive note,
have done.
I think the pediatrics community have certainly cared about cardiac toxicity, and as you saw today, in those Group B patients, they're only getting 120 of DOX, only a maximum of 240 in the highest risk group with the CNS positive, bone marrow positive disease greater than 25% blast. So I think, they've dialed down that, they've dialed down Cytoxan, fertility is spared in the majority, and really late effects in the NHL high-grade lymphoma patient populations has really been very, very minimal. And I think that's where the community comes from. But you're right, Wyndham, we do have to keep debating this, and that's why I'm saying we need to all come together. It shouldn't be an us or them situation. We should all be coming together and designing sensible trials and for these specific populations. So,
I mean, just to say it one more time, there is much that the pediatrics could learn from adult trials in young adults, and yet they've not wanted to apply that. And that's why we actually had this session. And I think that you and we are all on the same page. There's much that can be learned and needs to be learned to move these things forward quicker.
What we want you to do is have that debate at a pediatric session
Correct.
where it's pediatricians that hear it. But you're right, it's driven so much by the vast majority of pediatricians are focusing on their most common cancer, ALL.
Yes, exactly.
So moving on from a disease that we cure to thinking about the salvage therapies for those that we don't. So a whole session on immunotherapies and two very big talks on CAR T-cells, which look like they're emerging as, the non-Hodgkin's lymphomas are really looking like this is an approach that can be very effective. What did you make of the sessions there?
So I think the two talks given by Jim Cockendorfer at NCI and David Maloney from Seattle, plus the discussion that followed, which include discussion from the group at UPenn, who really are the three big groups, plus Sloan Kettering, who are participating in the CD19 CAR T-cell studies. It has to be really put out there that each study uses a different type of CAR, uses a different type of conditioning regimen, and...
Although I was hearing a little bit of coming together today.
There's a little bit of coming together, but there's certainly differences, and yet when you look at the results, they're all really outstanding for a chemo-refractory, heavily pretreated patient population of diffuse large B-cell lymphoma. And no matter which group you're looking at, we're looking at an event-free survival rate, a complete or response rate of around about 50-55%. And I think we heard today from the NCI that if you get in a CR, 11 of those 12 patients who got in a CR, they have been durable. So it really is, although the field is so young, it's a really exciting therapy. So the next question that was raised though is, well, there's other immunotherapies out there, there's checkpoint inhibitors, there's Bites, there's Darts, they're off the shelf, why go through this complex manufacturing process, etc., etc. And I think that while that is a valid argument, there's complexity to giving those other immunomodulatory agents, and we have to, but we as a cell therapy community have to really make sure that what we're giving is simple, that we can manage toxicities in a very sort of structured way, and really learn from how we broadened the applicability of bone marrow transplant many, many decades ago, and bring that now to the CAR T-cell field and other cell therapies going forward.
The whole session made it clear there are so many different immunotherapeutic approaches we could be thinking about and so many potential combinations. There are almost more clinical trials than we could have patients do it, particularly as long as the CAR T-cell field remains such a boutique type, only a few centres able to have the resources to be able to do this. Is it really ready for moving out to prime time the way, there's lots of the clinical trials looking to be now sending those cells out to other centres. Do you think that is the way the field should go, or do you think it should remain kind of very specialised field?
I definitely think if this field's going to survive, it has to move out for sure. And certainly there are international trials going on, multi-centre trials with CD19 CAR T-cells. So I think it's happening now. I actually think what might be a rate-limiting step ultimately, certainly in the US, is what the price point of these agents will be, and how that price will compare to modalities like bone marrow transplant or to Bites, for example, or to checkpoint inhibitors. So the field where it's a really exciting time to be in immunotherapy and in particular cell therapy, and you're right, I think we need to go to combination studies, but we're going to have to pick those combination studies wisely because we don't have enough patients to do every single possible combination that we might want to do.
So, I was just going to remark that many hospitals now, or many major centers, are actually doing CAR therapy. And one thing I do worry about is if we start to see these proliferate across many institutions that perhaps don't have the expertise. We hear about how this can be an outpatient therapy, how it's well tolerated, but then there are...
I heard outpatient followed by ITU admission.
But that was the exact point. But then you end up with people who end up having seizures, going to the ICU, and despite the discussions about how well tolerated it is, multiple people have died from these therapies. So I think that we have to know a lot more about who are the candidates for them, but I also think that they need to be done in pretty limited specialized sites.
Now then we moved on to the session looking at focusing at the beginning of the session certainly on circulating DNA as markers of disease. So what do you take from that session?
Well, I really think that it's got two things that it really is going to be useful for. We spend a lot of time imaging to determine if somebody is in a CR, and that predicts long-term outcome. However, for a lot of diseases, and let me just talk more about indolent ones, where we don't typically think of them being cured, I think that tests like this may allow us to understand that some of those patients are actually cured. If you actually look at long-term outcomes of patients with follicular lymphoma, they get chemotherapy, the curves plateau off at around 25%, and they never relapse out at 10 years, 20 years, etc. So this notion that we don't cure people with follicular lymphoma is probably untrue. And I think that if we have more sensitive methods of identifying a priori those cases that we can predict will be free of disease years later, I think we can begin to understand those people who do well, and I think by understanding who does well, that also gives us a comparator for people who don't do well, and perhaps identifying targets. It can also be used to get a handle on who's going to relapse with large cell earlier. But for me, the most exciting area here is these represent liquid biopsies where we can identify specific and perhaps targetable mutations up front, as well as clonogenic selection that may be leading to treatment failures. And so I think it is in those two areas that these technologies can be very, very useful. But they're still at the research phase.
Sure. And potentially useful also in the immunotherapy setting, where we could imagine escape variants, new mutations appearing, new need for education may be very useful. So we could perhaps tie it all together. Well, there you have it, a quick summary on day one of iwNHL. Very exciting day, lots of discussion among the delegates as always. And we look forward very much to more of the same for day two.